The discharge papers are already printed when I hear it. A whisper, soft enough that I almost miss it over the hum of monitors and the distant beep of call buttons down the hall. But I catch it, that single sentence that makes my hand freeze halfway to the clipboard. She's faking again, just like before. I look up. Bay 11. The curtain is pulled halfway, giving me a sliver of view into the treatment area. 16-year-old Madison Torres sits on the edge of the gurney, her legs dangling, one hand pressed against her chest. Her face is pale but not alarmingly so. Her vital signs have been stable for the past hour. Heart rate 88, blood pressure 118/70, oxygen saturation 99% on room air. Her mother stands beside her, arms crossed, jaw tight. Mrs. Torres Jennifer, according to the chart, is 42 years old, dressed in business casual, her hair pulled back in a ponytail that started to come loose. She looks exhausted. Not the exhaustion of a worried parent, the exhaustion of someone who's been through this too many times. Madison's eyes are closed, her breathing measured, but there's something about the way she's holding herself, the slight tremor in her shoulders, the way her other hand grips the edge of the gurney so hard her knuckles have gone white. I set the discharge papers down and step closer to the bay. Mrs. Torres? I keep my voice low, professional. Can I speak with you for a moment? She follows me a few steps away from the gurney, just outside the curtain. Her expression is guarded, defensive even before I've said anything. I was about to discharge Madison, I say carefully. Her EKG was normal. Her cardiac enzymes came back negative. Chest X-ray was clear. Everything points to anxiety. But I wanted to check with you first. Has she had episodes like this before? Episodes? Mrs. Torres's laugh is bitter. That's a polite way to put it. Yes, doctor. She's had episodes. Lots of them. At least once a month for the past year. Chest pain, can't breathe, thinks she's dying. Every single time the ER runs tests, tells us it's anxiety. Sends us home with a referral to a therapist. And has she been seeing a therapist? She went twice, refused to go back. Said the therapist didn't understand her. Mrs. Torres rubs her temples. Look, I know this sounds terrible. I know I sound like a horrible mother, but you don't understand. This started last year after her boyfriend broke up with her. Suddenly she couldn't go to school, couldn't be around crowds, had panic attacks about everything. We got her on medication. She went to therapy for a while. Things got better. And then this started. The chest pain, the shortness of breath, the dramatic hospital visits. And every single time they tell us it's anxiety, which it is. I know my daughter, doctor. When she's really sick, she powers through it. Last year she had the flu and still went to school because she had a chemistry test. But anxiety? She leans into it. Uses it to get attention, to get out of things she doesn't want to do. I glance back at Madison. She hasn't moved. Still sitting there, hand on chest, eyes closed. What was she supposed to be doing today? I ask. Mrs. Torres's expression tightens. There's a family dinner tonight. My parents are in town. Madison doesn't get along with them, long story, and she's been complaining all week about having to go. This morning, suddenly she has chest pain, can't breathe, needs to go to the A, but you brought her anyway, because what if I'm wrong? Mrs. Torres's voice cracks slightly. What if this time it's real, and I ignored it? I can't win, doctor. If I take her seriously, she learns that panic attacks get her what she wants. If I don't take her seriously, I'm a terrible mother who doesn't care about her daughter's health. I nod slowly, understanding the impossible position. Have her other visits all been at different hospitals? No, we usually come here, but different doctors every time. No one's seen the pattern except me. And the tests have always been normal? Always. EKG, blood work, X-rays, everything. Normal, normal, normal. And then they give her Ativan, she calms down, and we go home. Until the next time she doesn't want to do something. I look at the discharge papers in my hand. Everything Mrs. Torres is saying makes sense. The presentation fits anxiety. The history fits anxiety. The test results fit anxiety. But something is bothering me. It's the way Madison is sitting. The way she's breathing, not hyperventilating, not the rapid, shallow breaths of a panic attack, but controlled. almost too controlled, like she's trying very hard to breathe normally and it's taking all her concentration. Mrs. Torres, I say slowly, when Madison has these episodes, does she usually sit very still like this? Mrs. Torres frowns. No, usually she's more dramatic, crying, hyperventilating, saying she's going to die. This time she's been weirdly calm. She pauses. Is that significant? Maybe, maybe not. I hand her the discharge papers. Let me examine her one more time, just to be sure. Doctor, we've been here for 3 hours already. I have to get to work. Madison has homework. I understand. Give me 5 minutes. I don't wait for her to agree. I step back into the bay, pulling the curtain closed behind me. Madison? I pull up a stool, sit down so I'm at eye level with her. I'm Dr. Coleman. I know you've been here a while and you're probably ready to go home, but I want to make sure we're not missing anything. Can you tell me about your symptoms? She opens her eyes. They're brown, the same shade as her mother's, but where Mrs. Torres's eyes are sharp with frustration, Madison's are clouded with something else. Pain? Fear? It's hard to tell. My chest hurts, she says quietly. It started this morning. Right here. She moves her hand slightly, indicating the center of her chest. It feels like pressure, like someone's sitting on me. Classic cardiac symptom presentation, but also classic anxiety presentation. Does it radiate anywhere? Your arms, jaw, back? A little bit to my left arm, but mostly just here. Any shortness of breath? Yeah, I feel like I can't take a deep breath, like there's something stopping me. Any nausea? Sweating? No nausea. I was sweating earlier, but I think that was just because I was scared. I pull out my stethoscope. I'm going to listen to your heart and lungs, okay? She nods, and I notice the tremor in her hands has gotten worse. I place the stethoscope on her chest. Normal S1, S2, regular rate and rhythm, no murmurs. I move to her back, listen to her lungs, clear bilaterally. Take a deep breath for me. She tries. Gets about halfway through and stops, wincing. Does it hurt to breathe deeply? Yeah, sharp pain when I try to breathe in all the way. That's different. Anxiety doesn't usually cause pleuritic chest pain. Madison, has anyone in your family ever had heart problems? Heart attacks, arrhythmias, anything like that? My grandfather had a heart attack, but he was old, like 60-something. Any recent illnesses? Cold, flu, stomach bug? She thinks for a moment. I had a cold about 2 weeks ago. Nothing serious. Was over it in a few days. A cold 2 weeks ago. Pleuritic chest pain. Substernal pressure. Something clicks in my mind. Something I read in a journal article during my medical school cardiology rotation. Something rare. Something that could easily be mistaken for anxiety, especially in a teenage girl with a history of panic attacks. Madison, I need to ask you something, and I need you to be completely honest with me. Have you been using any drugs? Cocaine, methamphetamine, anything like that? No. Her answer is immediate, firm. I don't do drugs. I don't even drink. What about supplements? Energy drinks? Pre-workout powders? Just coffee sometimes. And I take vitamin D because my doctor said I was deficient. I stand up, pull out my phone, start scrolling through my medical reference app. Myocarditis, inflammation of the heart muscle, can be triggered by viral infections. Presents with chest pain, shortness of breath, sometimes mimics a heart attack. In young people, especially teenagers, it's rare but not unheard of, and it can be subtle enough on initial testing to slip through the cracks. The EKG was normal, but early myocarditis can have a normal EKG. The cardiac enzymes were negative, but I checked the chart. See that they were drawn only 90 minutes after symptom onset. Troponin can take hours to elevate. Madison, I want to keep you here a little longer. Run some additional tests. Her eyes widen. Is something wrong? I don't know yet, but I want to be sure. Mrs. Torres pushes the curtain aside. Doctor, what's going on? You said 5 minutes. I need to keep Madison for observation. I want to repeat her cardiac enzymes, get an echocardiogram, maybe a cardiac MRI depending on what we find. Are you serious? We've been through this before. Every test comes back normal because there's nothing wrong with her heart. It's anxiety. "Mrs. Torres, I understand your frustration, but Madison is presenting with some symptoms that concern me. Pleuritic chest pain, difficulty taking a deep breath, and she had a viral illness recently. I'm worried about myocarditis." Myo what? Inflammation of the heart muscle. It's rare, but it can follow viral infections, and it can be serious if left untreated. But her EKG was normal. Her blood tests were normal. Early myocarditis can have normal initial findings. That's why I want to keep her for observation and repeat the tests. Mrs. Torres looks at her daughter, then back at me. I can see the conflict on her face. The part of her that wants to believe this is just another anxiety episode. The part of her that's tired of the false alarms, the wasted time, the medical bills for tests that always come back normal. But also the part of her that's terrified of being wrong. How long? She asks finally. At least 6 hours. Maybe overnight depending on what we find. I have to call work. Tell them I'm not coming in. She pulls out her phone, walks a few steps away. I look at Madison. Her hand is still pressed against her chest, and her face has gone even paler. "Madison, are you okay?" "I feel dizzy," she whispers, "and my heart is beating really fast." I look at the monitor. Heart rate 142, up from 88 just minutes ago. Blood pressure 98/60 seconds, down from 118/70 seconds. "Madison, I need you to lie down. Right now." She starts to comply, but halfway through the movement, her eyes roll back and she collapses. "Madison," the monitor alarm screams. Heart rate 186. Blood pressure 82/48. "I need help in Bay 11. I yell, hitting the code button on the wall. "Adult code team to the A." Mrs. Torres spins around, her phone dropping from her hand. What's happening? What's wrong with her? I don't answer. I'm too busy trying to keep Madison alive. 7 hours earlier, the morning had started with a lecture that I'd already forgotten. Grand rounds, 6 a.m., conference room on the 3rd floor. Hassan Okafor, one of the senior cardiologists, presenting on atypical cardiac presentations in young adults. I'd sat in the back row with a cup of coffee that had gone cold halfway through, fighting to keep my eyes open after a night shift that had ended only 4 hours earlier. But one slide had caught my attention. A case study of a 17-year-old athlete who'd collapsed during basketball practice. Initial workup normal. Sent home with a diagnosis of dehydration and anxiety. Returned 3 days later in cardiogenic shock. Final diagnosis: fulminant myocarditis. The key takeaway, Dr. Okafor had said, his voice carrying the weight of experience, is that myocarditis is a great mimicker. It can look like anxiety, pneumonia, gastritis, or nothing at all. And in young people, we're often too quick to dismiss cardiac causes because we think they're too young for heart problems. He'd click to the next slide, showing the patient's cardiac MRI. The heart muscle was inflamed, enlarged, struggling to pump effectively. This young man survived, but he needed a heart transplant within 6 months. If we'd caught it earlier, if we'd been more vigilant, maybe we could have prevented that outcome. At the time, I'd thought it was an interesting case, but not particularly relevant to my day-to-day work in the A. Myocarditis was rare. The odds of seeing a case were low, but that slide had stuck with me, filed away in some corner of my brain, waiting. Now standing over Madison Torres's bed as the code team rushed in, I wished I'd paid closer attention. The A was quieter than usual that morning when I'd clocked in at 11 a.m. Monday mornings were unpredictable, sometimes slow, sometimes chaos. Today seemed to be leaning towards slow. "Dr. Coleman, you're with Dr. Martinez today," the charge nurse informed me. "She's running behind from a personal appointment, should be here by noon. Until then, you're taking walk-ins and anything triage sends your way." Dr. Elena Martinez was one of the newer attendings, only 3 years out of residency herself. She was known for being thorough, sometimes overly so. The kind of doctor who ordered every test, checked every box, never wanted to miss anything. Some residents found it tedious. I found it reassuring. The first few patients were routine. A man with a UTI, a woman with a sprained ankle, a kid who'd stuck a bead up his nose and needed it removed. I worked methodically through each case, documenting everything, following protocols. At 1:47 p.m., Madison Torres arrived. I pulled up her chart in triage. 16 years old, no significant past medical history except for anxiety disorder diagnosed last year. Chief complaint: chest pain and shortness of breath. Vitals: BP 118 70 HR 88, RR 18, SpO2 99% on room air, temp 98.4 degrees Fahrenheit. Everything looks stable. Probably anxiety, like the triage note suggested. But chest pain in anyone, even a teenager, required a cardiac workup. That was the standard of care. I grabbed a fresh gown and gloves and headed toward Bay 11. Madison was sitting on the gurney when I entered, her mother standing beside her looking impatient. The girl wore a school hoodie and jeans, her dark hair pulled into a messy bun. She looked like any other teenager, except for the way she was holding her chest, the slight grimace on her face. "Hi, I'm Dr. Coleman," I said, pulling up a stool. "Madison, I understand you're having chest pain?" "Yes." Her voice was soft, almost apologetic. "It started this morning when I woke up. Can you describe the pain for me? Sharp, dull, pressure?" "It feels like pressure, like someone's pressing down on my chest. And it hurts more when I try to take a deep breath." "Any pain radiating to your arms, jaw, or back?" "A little bit to my left arm. Classic anginal symptoms." But this was a 16-year-old girl. The odds of acute coronary syndrome were astronomically low unless she had significant risk factors. "Do you smoke? Use any drugs or medications?" "No, nothing like that." "Any family history of heart problems?" "Her grandfather had a heart attack," Mrs. Torres interjected. "But that was years ago, and he was much older." I nodded, making notes. "Madison, have you had chest pain like this before?" She hesitated, glancing at her mother. "Sort of. I've had chest pain before, but they said it was anxiety." "She has panic attacks," Mrs. Torres said, her tone clipped. "Started last year. We've been to the EO several times for this exact thing. Every time they run tests, everything's normal, and they send us home." I looked between mother and daughter. There was tension there, palpable even in the brief exchange. "Okay," I said carefully. "We're going to run some tests today too, just to make sure everything's okay. Madison, I'm going to listen to your heart and lungs. Then we'll get an EKG and some blood work. Sound good?" She nodded. The physical exam was unremarkable. Heart sounds normal, lungs clear. No signs of respiratory distress despite her complaints of shortness of breath. Her oxygen saturation remained at 99%, which argued against any significant pulmonary or cardiac pathology. "I'm going to order an EKG, chest X-ray, and cardiac enzymes," I told them. "These are standard tests for chest pain. The EKG looks at your heart's electrical activity. The X-ray checks your lungs and heart size. And the cardiac enzymes are blood tests that can show if there's any heart muscle damage." "How long will this take?" Mrs. Torres asked. "I'm supposed to be at work in an hour. The tests themselves don't take long. EKG is about 5 minutes. X-ray maybe 10. Blood draw just a minute. But we'll need to wait for the results to come back, which usually takes about an hour." Mrs. Torres sighed, but didn't argue. I put in the orders and moved on to my next patient. Bay 3 had a homeless man with a foot infection. Bay 7 was a construction worker with a laceration that needed suturing. Bay 9 was an elderly woman with altered mental status, possible UTI, possible dementia. We'd need to work her up. It was almost 3 p.m. when Madison's test results started coming back. EKG, normal sinus rhythm, no Saint changes, no T-wave abnormalities, no signs of ischemia or infarction. Chest X-ray, clear lung fields, normal cardiac silhouette, no infiltrates or effusions. Cardiac enzymes, troponin I, 0.01 ng/ml, normal, below threshold for myocardial injury. Everything was normal. Exactly what I'd expected. I printed the discharge papers, grabbed a prescription pad to write for a low-dose benzodiazepine for anxiety if Mrs. Torres wanted it, and headed back to Bay 11. That's when I heard it, that whisper that changed everything. "She's faking again, just like before." The code team arrives in seconds. 2 nurses, a respiratory therapist, a senior resident I recognize from the ICU. They move with practiced efficiency, each person taking their position around Madison's bed. What happened? The senior resident Dr. Sarah Chen asks as she checks Madison's pulse. 16-year-old female, presented with chest pain and dyspnea. Was stable, normal initial workup. I was preparing to discharge when she suddenly became tachycardic and hypotensive, then lost consciousness. V-tach? Chun asks, looking at the monitor. Sinus tach. Rates 186. Pressures 82/48. Madison's eyes flutter open. She looks confused, disoriented. What happened? You passed out, I tell her, keeping my voice calm. Just lie still for a moment. Mrs. Torres is pressed against the wall, her face white. Is she okay? Is she having a heart attack? We're evaluating her, Chun says, not looking away from Madison. Can you tell me your name? Madison. Madison Torres. What year is it, Madison? 2024. Her voice is weak but clear. Good. Can you squeeze my hands? Madison squeezes. Equal grip strength bilaterally. Chun nods, satisfied there's no focal neurological deficit. Let's get another set of vitals, repeat EKG, and I want another troponin draw. Also, get me a BNP and a D-dimer. The nurses move to comply. One starts a second IV line. Another preps for the blood draw. Should we start fluids? I ask. Let's see if the pressure comes up on its own first. If not, we'll bolus. Chun turns to me. What made you keep her instead of discharging? Pleuritic chest pain. History of recent viral illness. It didn't fit with anxiety. And the initial troponin was negative? Drawn 90 minutes after symptom onset. Chun nods. Could still be early. What's your working diagnosis? Myocarditis. In a 16-year-old? It happens. And it can present exactly like this: chest pain, dyspnea, tachycardia. The prodromal viral illness fits. Or it could be a PEI, or a spontaneous pneumothorax, or even anxiety with syncope. Chun doesn't sound dismissive, just thorough. Let's not get anchored on one diagnosis. We'll work her up broadly. The monitor beeps. Heart rate coming down slightly, 164 now. Blood pressure up to 94/58. Talk to me, Madison, Chun says. How are you feeling right now? Dizzy, and my chest hurts more than before. It's really hard to breathe. Are you anxious? I'm scared, but it's not like my panic attacks. Those feel different. Mrs. Torres pushes forward. How do they feel different, honey? Madison looks at her mother, and I see something pass between them. A moment of understanding, or maybe just recognition. Panic attacks make my head feel weird, like I'm going to lose control. This just feels like my chest is going to explode. One of the nurses hands Chun the EKG printout. She studies it, frowning. SD elevation in leads 2, 3, and a VF. And look at this PR depression. She hands it to me. I see what she's seeing. The changes are subtle, but they're there. ST elevation suggesting injury to the inferior wall of the heart. PR depression suggesting pericardial involvement. That wasn't there on the first EKG, I say. Because whatever's happening is evolving. Chun looks at Madison, her expression serious. Madison, we need to admit you to the hospital. You're showing signs of heart inflammation, possibly myocarditis or pericarditis. We need to do more tests, monitor you closely, and start treatment. Heart inflammation? Mrs. Torres's voice rises. But she's 16. How can she have heart inflammation? It can happen after viral infections, Chun explains. The virus triggers an inflammatory response that affects the heart muscle or the lining around the heart. It's not common, but it's not unheard of, especially in young people. But all her other tests were normal. All those times we came to the A. This may be a new development. Or it may have been brewing for a while and we're just catching it now. Chun turns back to Madison. Have you been unusually tired lately? Any episodes where your heart was racing for no reason? Madison thinks. I've been tired, but I thought it was just school stress. And yeah, sometimes my heart races, but I thought that was anxiety. Any fainting episodes before today? No, well, I felt dizzy a few times, but I never actually passed out. The second troponin comes back. 0.24 ng/ml. Elevated, not massively, but definitely above normal. There's your answer, Chun says to me. Troponin is rising. She's having an acute cardiac event. My stomach drops. An acute cardiac event in a 16-year-old girl. If I'd discharged her based on the initial workup, if I'd listened to her mother's assertion that she was faking ... I need to call cardiology, Chun says. She needs an echo, probably a cardiac MRI, maybe a cardiac catheterization depending on what they find. She looks at Mrs. Torres. Does your daughter have any drug allergies we should know about? No allergies. Mrs. Torres sounds dazed. I don't understand. How did this happen? She was fine last week. Viral myocarditis can develop rapidly, Chun explains. The good news is we caught it. If we'd sent her home and this had progressed ... She doesn't finish the sentence. She doesn't need to. I think about Madison collapsing at home, maybe alone. Heart going into a lethal arrhythmia, no one there to help. The thought makes me nauseous. Dr. Coleman, good catch, Chun says to me. Seriously, most people would have discharged her. I nod, but I don't feel good about it. I feel sick, because I almost did discharge her. I was literally holding the discharge papers when I heard Mrs. Torres's comment. She's faking again, just like before. If I hadn't overheard that, if I hadn't decided to do one more examination, if I just trusted the normal initial workup, Madison would be dead. The next hour is controlled chaos. Cardiology arrives a fellow named Dr. Jason Park, who looks too young to be a cardiologist but has a reputation for being brilliant. He examines Madison, reviews her EKGs, orders an echocardiogram stat. The echo tech wheels her portable machine into the bay. Mrs. Torres and I are asked to step out while they do the exam. We stand in the hallway. The sound of the AU continuing around us, monitors beeping, phones ringing, the distant sound of someone crying in another bay. This is really happening, Mrs. Torres says quietly. She's really sick. Yes, I thought she was faking. I was so sure she was faking. She looks at me, her eyes filled with tears. What kind of mother thinks her daughter is faking a heart attack? Mrs. Torres, you couldn't have known. I should have known. She kept saying it felt different this time, that it wasn't like her panic attacks, and I dismissed her. I thought she was just getting more creative with her manipulations. I don't know what to say to that, because the truth is, Mrs. Torres had reason to be skeptical. Madison did have a history of panic attacks. She had been to the EO multiple times with similar symptoms that turned out to be anxiety. The pattern was there, but patterns can blind us. They can make us see what we expect to see instead of what's actually there. The important thing is that we caught it now, I say, before something worse happened. But what if you hadn't? What if you'd listened to me and sent her home? What if she'd... Mrs. Torres can't finish the sentence. Dr. Park emerges from the bay, his expression grave. Mrs. Torres, can you come in? I want to show you what we found. We follow him back inside. Madison is lying flat on the gurney now, an oxygen cannula in her nose. The echo machine screen shows grainy black and white images of her heart, the chambers contracting and relaxing, valves opening and closing. This is your daughter's heart, Park says, pointing to the screen. See how the left ventricle, this chamber here, isn't contracting as well as it should. The ejection fraction is only about 35%. Normal is 50 to 70%. Mrs. Torres stares at the screen. What does that mean? It means her heart isn't pumping efficiently. The muscle is inflamed and weakened. We also see some pericardial effusion fluid around the heart, which suggests both myocarditis and pericarditis. Is she going to die? Park's expression softens. We're going to do everything we can to prevent that. But I won't lie to you, this is serious. Myocarditis can progress rapidly. She needs to be admitted to the cardiac care unit for close monitoring. We'll start her on anti-inflammatory medications, diuretics to help reduce the fluid overload, and medications to support her heart function. What caused this? Most likely a viral infection. You said she had a cold a couple of weeks ago? Yes, but it was just a cold. She was barely even sick. Sometimes that's all it takes. The virus can trigger an autoimmune response where the body attacks its own heart tissue. It's not common, but it happens. Madison has been quiet through this exchange, listening but not speaking. Now she says, "Am I going to need a heart transplant? Like, forever?" Park sits down on the stool beside her. Most people with viral myocarditis recover fully with treatment. Their hearts heal, their function returns to normal, and they go on to live completely normal lives. But there's a subset, maybe 10 to 20%, who don't recover fully. Some develop chronic heart failure. Some need transplants eventually. Which group am I in? We don't know yet. It's too early to tell. But you're young, you were healthy before this, and we caught it relatively early. Those are all factors in your favor. Relatively early, Mrs. Torres repeats. But she's been having symptoms for weeks, hasn't she? All those times I thought she was faking, those were real symptoms? Park hesitates. Not necessarily. Panic attacks and anxiety can cause chest pain and shortness of breath. It's possible those earlier episodes were anxiety. This acute episode, though, this is definitely cardiac in origin. Or maybe it's been brewing for weeks and we kept dismissing it as anxiety, I say quietly. Park looks at me, considering. That's possible too. Myocarditis can be insidious. Early symptoms can be vague fatigue, mild chest discomfort, palpitations, things that could easily be attributed to other causes. Oh God, Mrs. Torres puts her head in her hands. I've been dragging her to therapy, putting her on anxiety medications, telling her it was all in her head, and the whole time her heart was failing. Mrs. Torres, you can't blame yourself for this, Park says firmly. Even if some of her earlier symptoms were cardiac in origin, they were mild enough that multiple visits with workups didn't catch them. This isn't your fault, but I can see from Mrs. Torres's expression that she doesn't believe him. She's going to carry this guilt for a long time. A nurse appears in the doorway. Dr. Park, CCU is ready for her. They want to get her upstairs and on continuous telemetry. Good, let's move her. Park turns to Madison. You're going to spend the next few days in the cardiac care unit. It's basically an ICU for heart patients. You'll be on monitors continuously. Nurses will be checking on you constantly and will be running more tests. It's going to be boring and uncomfortable, but it's necessary. Okay, Madison says quietly. She looks scared but also relieved. Like she's grateful someone finally believes she's sick. We transfer her to a transport gurney. Mrs. Torres gathers Madison's backpack and jacket. I walk with them toward the elevators. Dr. Coleman, Madison says as we wait for the elevator. Thank you for believing me. I'm sorry I almost didn't, I say honestly. You did though. That's what matters. The elevator arrives. Park, Madison, Mrs. Torres, and 2 nurses get in. I stay behind, watching the doors close. Then I turn and walk back to the A, my mind spinning. Dr. Martinez has arrived by the time I get back to the nurses' station. She's reviewing charts, catching up on what she missed during her late start. Dr. Coleman, I heard you had an interesting case, she says without looking up. Teenage girl with myocarditis? Yeah, almost missed it, but you didn't. That's what counts. She finally looks at me. Walk me through your decision-making process. What made you keep her instead of discharging? I explained the whole situation, the initial presentation, the normal workup, the mother's comment about faking, my decision to re-examine Madison, the pleuritic chest pain, the syncopal episode. Martinez listens without interrupting. When I finish, she nods slowly. You followed your instincts. That's good. But instincts aren't enough in emergency medicine. You need to have a systematic approach, especially with presentations like this that can go either way. I know. I'm struggling with how close it was. If I hadn't overheard the mother's comment, if I hadn't gone back for one more look, I would have discharged her, and she probably would have died. Maybe. Or maybe you would have caught it anyway because you're the kind of doctor who triple checks things. Don't second guess yourself too much, Marcus. You did good work today. It doesn't feel like good work. It feels like I got lucky. Sometimes in medicine, luck is part of it. But you also made your own luck by being thorough, by not accepting the easy explanation, by listening to that voice in your head that said something wasn't right. She hands me a new chart. Now Bay 14 needs a suture consult. Can you handle that? Yeah, I got it. I take the chart and head toward Bay 14, but my mind is still on Madison, on her mother's guilt-stricken face, on how easy it would have been to dismiss a teenage girl with a history of anxiety. The rest of the shift passes in a blur. More patients, more charts, more decisions. None as dramatic as Madison, but each one requiring the same careful attention, the same systematic approach, the same willingness to question initial assumptions. By the time my shift ends at 11 p.m., I'm exhausted. But before I leave, I check my computer one more time, pull up Madison's chart. She's stable in the CCU. Heart rate 92, blood pressure 106/68, oxygen saturation 97% on 2 liters. Still tachycardic, still hypotensive, but better than before. The notes show she's on a regimen of anti-inflammatories, ACE inhibitors, and diuretics. There's a note from Dr. Park, patient resting comfortably, mother at bedside. Plan for cardiac MRI in AM to assess extent of inflammation. Will repeat echo in 48 hours to monitor cardiac function. I close the chart and head home, driving through empty streets, my mind churning with what-ifs and maybes. What if Mrs. Torres hadn't said anything? What if I just handed her those discharge papers and sent them on their way? But she did say something, and I did listen, and Madison is alive because of it. Sometimes that has to be enough. The next morning, I'm not scheduled to work, but I find myself back at the hospital anyway. I tell myself it's to review some cases to catch up on documentation, but really, I want to check on Madison. The CCU is on the 5th floor, a quiet unit with large windows and a view of the city. Each patient room has glass walls facing the nurses' station, allowing for constant visual monitoring. Privacy curtains can be drawn, but most patients leave them open, preferring connection over isolation. Madison's room is the 3rd one on the right. Mrs. Torres is sitting in a chair beside the bed, her laptop open but ignored. Madison is awake, propped up on pillows, an oxygen cannula in her nose. She looks better than yesterday, less pale, less scared. I knock softly on the glass. Mrs. Torres looks up, waves me in. "Dr. Coleman," she says. "I didn't expect to see you here. I wanted to check on how Madison's doing. I hope that's okay." "Of course. We're actually glad you're here." She glances at her daughter. "Madison wanted to talk to you." I pull up a chair. "What's up?" Madison fidgets with the blanket. "I wanted to say thank you again, and to apologize." Apologize for what? For making everyone think I was faking. I know my mom thought I was being dramatic, and I know the other doctors probably thought the same thing, but I really was feeling bad. I wasn't making it up. "Madison, you don't need to apologize for being sick." But I do, kind of. Because some of it was anxiety. Like, I did have panic attacks last year. Those were real, and they did cause chest pain. So I understand why everyone thought this was the same thing. Mrs. Torres reaches over and takes her daughter's hand. "We should have listened to you more carefully. When you said it felt different, we should have believed you." "It's hard to explain," Madison says. "The panic attacks felt like my brain was going crazy. This felt like my body was breaking. Does that make sense?" "It does," I say. And it's actually a really important distinction. Physical symptoms can come from psychological causes, anxiety, stress, depression, but they can also come from actual physical disease. And sometimes both are happening at the same time. That's what the cardiologist said. He said the anxiety might have made me more aware of my heart symptoms. Like, if I wasn't already worried about my heart, I might have ignored the early signs. That's possible. Anxiety can make people hypervigilant about their bodies. So the anxiety actually helped? Madison looks surprised. In a weird way, yeah. It made you pay attention to symptoms that otherwise might have been dismissed until they got much worse. Mrs. Torres shakes her head. "I still can't believe we're here. 24 hours ago, I thought my daughter was manipulating me to get out of a family dinner. Now she's in cardiac care with an inflamed heart. How did the family dinner go?" I ask, attempting a little levity. Mrs. Torres laughs, a sound with no humor in it. "We canceled. My parents were upset, thought we were being dramatic." Until I sent them a picture of Madison in the CCU. Then they understood. Are they here? They're flying back tomorrow. Cutting their visit short to come back when Madison gets discharged. She pauses. Which brings up a question, when will she be discharged? And what's the long-term prognosis? I'm not the cardiologist, so I can't give you definitive answers. But typically with myocarditis, if the patient responds well to treatment, hospital stays range from a few days to a couple of weeks. Long-term prognosis depends on how much permanent damage there is. Dr. Park said I might need a transplant eventually, Madison says quietly. Like, if my heart doesn't heal, that's worst-case scenario. Most people with viral myocarditis recover fully, but some don't. No, I admit. Some don't. A nurse enters, carrying a tray of medications. Time for your morning meds, Madison. I stand up. I should let you rest, but I'll check in again if that's okay. That's more than okay, Mrs. Torres says. Thank you, Dr. Coleman, for everything. I leave the CCU and head down to the cafeteria. It's early enough that the breakfast rush hasn't started yet. I grab coffee and a bagel, find a table by the window. My phone buzzes. A text from Dr. Patel. Heard about your myocarditis case yesterday. Well done. I type back. Almost missed it. Her response comes immediately. But you didn't. Stop second-guessing yourself. Easier said than done. I finish my coffee and head down to the A, even though I'm not on shift. Maybe I can help out, review some charts, learn something. The morning shift is in full swing. Dr. Hendry is the attending, and he waves me over when he sees me. Dr. Coleman, what are you doing here on your day off? Couldn't stay away. Thought I might review some cases. Or you're obsessing about the myocarditis case, he says knowingly. Which, by the way, nice catch. But you need to learn to let cases go once they're out of your hands. Otherwise, this job will destroy you. I know. I'm working on it. Work harder. Now if you're here anyway, Bay 8 needs a laceration repair. Think you can handle that? Yeah, I got it. The day passes quickly. Between cases, I keep checking my phone, looking for updates on Madison. But there's nothing. Until 3 p.m. when my pager goes off. CCU. Stat. My heart drops. I run for the stairs, taking them 2 at a time, my mind racing with possibilities. Cardiac arrest, arrhythmia, sudden deterioration. When I burst through the CCU doors, I'm breathing hard. The nurses look up in surprise. Who paged me? I ask. No one paged you, one of them says. I got a page from the CCU. Code stat. She checks the paging system. There's no active code. Everything's quiet up here. I pull out my pager, check the number. It's the CCU extension, but there's no indication of what kind of page it was. Maybe it was a mistake, the nurse suggests. Or maybe my anxiety is making me see things that aren't there. I'm about to leave when I see Dr. Park emerging from Madison's room. He sees me and waves me over. Dr. Coleman, good timing. I wanted to talk to you about Madison's MRI results. Is everything okay? Better than okay. The MRI shows inflammation, as expected, but it's diffuse and relatively mild. No focal areas of scarring or necrosis. Her ejection fraction has already improved to 42%. With treatment, I expect you make a full recovery. Relief floods through me. That's great news. It is. And I wanted to thank you for catching this when you did. If she'd gone home and this had progressed, we could have been looking at a very different outcome. I almost sent her home, but you didn't. That's what matters. Park pulls out his phone, shows me an image. This is her cardiac MRI. See the areas of bright signal in the myocardium. That's inflammation, but it's not extensive, and with anti-inflammatory treatment, it should resolve. How long will she need to be on medications? Probably several months. We'll monitor her cardiac function closely, repeat echoes monthly. If she continues to improve, we can start tapering meds after 3 to 6 months. And long term, can she go back to normal activities? Eventually, yes. But you need to avoid strenuous exercise for at least 6 months. No sports, no gym class, nothing that elevates her heart rate significantly. After that, if her function is normal, she can gradually resume activities. That's going to be hard for a 16-year-old. It is. But it's better than the alternative. Park checks his watch. I need to get to clinic. But thanks again, Dr. Coleman. Good instincts. I watch him walk away, then turn back toward Madison's room. Through the glass wall, I can see her sitting up, talking to her mother. She looks animated, gesturing with her hands, almost like a normal teenager instead of a cardiac patient. Mrs. Torres sees me watching and motions for me to come in. Dr. Park told us the good news, she says, her face brighter than I've seen it. Madison's going to be okay, I heard. That's wonderful. He said if you hadn't caught it when you did, things could have been much worse. Mrs. Torres's voice cracked slightly. I still can't believe I almost convinced you to send her home. Mrs. Torres, you were working with the information you had. No one blames you. I blame myself. I spent a year thinking my daughter was manipulating me, using her anxiety to get attention, to get out of things she didn't want to do. And I became so skeptical that I almost missed when she was really sick. Madison reaches for her mother's hand. Mom, stop. You brought me to the You stayed with me. You advocated for me when I couldn't advocate for myself. That's what matters. But I told the doctor you were faking, and Dr. Coleman didn't listen to you. He did his job. He checked me out thoroughly. He didn't let your opinion override his judgment. Madison looks at me. Right? Right, I say. Although I did almost listen to your mom. The initial tests were all normal, and your history of anxiety was pretty convincing. If I hadn't decided to do one more examination, if I hadn't caught that subtle change in your symptoms, ... But you did, Madison says firmly. You did your job. Mom did her job by bringing me in. Everyone did what they were supposed to do. Can we please stop with the guilt? Mrs. Torres and I exchange a look. Madison is right, of course. But guilt isn't rational. It doesn't respond to logic or reassurance. When do you think you'll be discharged? I ask, changing the subject. Dr. Park said maybe in 3 or 4 days if I keep improving. Then I'll need to come back for follow-up appointments every week. And no school for a while, Mrs. Torres adds. Home tutoring until she's stable enough to go back. Madison makes a face. Great. More time stuck at home. You'll live, her mother says dryly. Unlike the alternative, the tension breaks and Madison laughs. It's a small sound but genuine. I excuse myself and head back to the A, feeling lighter than I have since this whole thing started. Madison is going to be okay. Her heart is going to heal. She'll go back to being a normal teenager, with normal teenage problems. And this will become just a story she tells about that time she almost died. But I'll remember it. I'll remember how close it was. How easily I could have missed it. How important it is to listen, not just to test results, but to patience. To trust instincts, even when the data seems clear. This is what emergency medicine is about. Not the dramatic saves that make for good TV, but the quiet moments of decision-making. The choice to do one more test, one more exam, one more check. The willingness to question initial assumptions and dig deeper when something doesn't quite fit. Sometimes you get it right. Sometimes you get lucky. And sometimes, if you're very fortunate, you get both. 4 days later, Madison is discharged from the hospital. I'm not there for it. I'm on shift in the A, but I get a text from Mrs. Torres with a photo of Madison sitting in a wheelchair by the hospital entrance, ready to go home. She's smiling, holding a balloon that says, "Get well soon," still wearing an oxygen cannula but looking infinitely better than she did a week ago. The text says, "Heading home. Thank you for everything." I save the photo, a reminder of why I chose this profession. Over the next few weeks, I follow Madison's progress through the medical record. Weekly echo appointments showing steadily improving cardiac function. Ejection fraction up to 48%, then 52%, then 55%. Troponin levels normalizing. Inflammatory markers decreasing. Dr. Park's notes are optimistic. Patient responding well to treatment. Anticipate full recovery with continued medical management. 1 month after her initial presentation, I'm walking through the hospital lobby when I see them. Madison and Mrs. Torres coming in for a follow-up appointment. Madison is walking on her own. No wheelchair, no oxygen, looking like any other teenager in jeans and a hoodie. "Dr. Coleman," Madison sees me first, waves enthusiastically. I walk over. Madison, you look great. How are you feeling? So much better. I can actually breathe now without feeling like my chest is going to explode. That's wonderful. How's the medication regimen going? Annoying, she admits. I have to take like 5 different pills twice a day. But Dr. Park says if I keep improving, he can start reducing them in another month or 2. And school? Back at school, but taking it easy. No gym class, no sports. I'm basically the girl who sits on the sidelines with a doctor's note. She makes a face. It's boring, but it beats being in the hospital. Mrs. Torres has been quiet, but now she speaks up. We also started family therapy, working through some of the trust issues that developed last year. That's great. How's it going? It's hard, Madison says honestly, but necessary. Mom and I have a lot to work through. The anxiety, the way we both handled it, the fact that she didn't believe me when I was really sick. I'm trying to do better, Mrs. Torres says quietly. To listen more, to not automatically assume she's being dramatic. It's a process. It is, I agree. But the fact that you're both working on it, that's what matters. Madison's phone buzzes. She checks it. Our appointment's in 5 minutes. We should get going. It was good to see you both, I say. You too, Dr. Coleman. Thank you again for saving my life. You're welcome. Take care of yourself. I watch them head toward the elevators, toward another follow-up appointment, another step in Madison's recovery. And I think about all the patients I see. The ones who recover, the ones who don't, the ones where we make the right call, and the ones where we don't. Medicine is humbling. It reminds you constantly that you don't know everything, that you can miss things, that sometimes the difference between life and death is one decision, one moment, one choice to keep looking when everything seems clear. I head back to the EA, back to the chaos and the uncertainty and the endless stream of patients who need help. This is what I signed up for. The responsibility, the weight of decision-making, the knowledge that every patient who walks through those doors is trusting me with their life. It's terrifying. It's exhausting. It's the most important thing I'll ever do. And I wouldn't trade it for anything. 6 months after Madison's discharge, I'm sitting in a conference room for another Grand Rounds presentation. Different speaker this time, Dr. Park, the cardiologist who took care of Madison. His presentation is titled, Myocarditis in Adolescence, a Case Study in Clinical Vigilance. The first slide shows a teenage girl sitting in an A bead, hand pressed against her chest. I recognize her immediately, Madison. This is a 16-year-old female who presented to our with chest pain and dyspnea. Park begins. Initial workup was normal EKG unremarkable, cardiac enzymes negative, chest X-ray clear. She had a history of anxiety and panic attacks and had been to the ER multiple times with similar symptoms that were always attributed to anxiety. He clicks to the next slide. It shows her discharge papers. The resident who saw her initially was preparing to discharge her with a diagnosis of anxiety, but something made him pause. Something made him go back and examine her one more time. Click. A slide showing the second EKG, the one with subtle street elevations. That second examination revealed pleuritic chest pain, recent viral illness, and shortly after, the patient became hemodynamically unstable. Repeat EKG showed new changes. Repeat troponin was elevated. Echo showed reduced ejection fraction and pericardial effusion. Click. The cardiac MRI showing inflammation throughout the myocardium. Final diagnosis: acute viral myocarditis with pericarditis. The patient was admitted to the CCU, treated with anti-inflammatories and supportive care, and made a full recovery. Her ejection fraction is now 62%, completely normal for her age. She's back in school, back to her regular activities, living a normal teenage life. Click. A slide showing Madison 6 months later at her final follow-up appointment, smiling and healthy. The key learning point here is about clinical vigilance. This patient had every reason to be dismissed. History of anxiety, multiple prior A visits, normal initial workup, but the resident didn't stop there. He questioned his assumptions. He did a thorough secondary assessment. He recognized subtle changes that others might have missed. Park looks around the room. How many of us would have discharged her based on that initial workup? Be honest. Most of the hands in the room go up, including mine. Exactly. Because that's what we're trained to do. We're trained to look for patterns, to make efficient decisions, to use algorithms and protocols. But we also need to be trained to question those patterns when something doesn't fit, to trust our instincts even when the data seems clear. He clicks to a new slide. It's a quote. In medicine, the art is knowing when to follow the science and when to trust your gut. This patient is alive because a resident trusted his gut, because he decided to look one more time when everything seemed clear, because he didn't let a normal workup override his clinical suspicion. Park closes his presentation. So my challenge to all of you, especially the residents and students in the room, don't be afraid to question initial findings. Don't be afraid to do that second exam, order that additional test, keep a patient for observation when something feels off. Yes, you'll be wrong sometimes. Yes, you'll order unnecessary tests and keep people longer than needed. But you'll also catch the cases that matter. You'll save lives that would have been lost. The room is quiet for a moment. Then someone starts clapping. Others join in. Within seconds, the entire room is applauding. I sit there, feeling a complex mix of emotions. Pride that Madison's case is being used as a teaching tool. Embarrassment that my near miss is being highlighted. Gratitude that it worked out the way it did. After the presentation ends, Park finds me in the hallway. I hope you don't mind that I used Madison's case, he says. I didn't use your name, but anyone who was working that day probably knows it was you. I don't mind. If it helps people learn, that's what matters. It will. Cases like this stick with people. They remember the patient, the story, the lesson. He pauses. Madison wants to thank you, by the way. She wrote you a letter. Her mom's going to drop it off at the ER later today. She doesn't need to thank me. She wants to. Let her. The letter arrives that afternoon, delivered by a courier in a sealed envelope with my name written in neat teenage handwriting. I open it during a quiet moment in the shift, sitting at the nurse's station with a cup of coffee. Dear Dr. Coleman, I'm not great at writing letters, but my mom said I should tell you how I'm doing and thank you properly. So here goes. I'm doing really well. My heart is back to normal, doctor. Park says I have the heart of a healthy teenager again, which is funny because 6 months ago, I had the heart of someone much older and sicker. I'm back at school full-time. I'm playing in the school band again, flute in case you were wondering. And I'm even thinking about trying out for track next year if Dr. Park clears me. But more than the physical recovery, I wanted to tell you about the other ways my life has changed. My mom and I are closer now than we've been in years. We went through family therapy together, and we both learned a lot about communication and trust. She learned to take my concerns seriously, and I learned to express myself better. We still have our moments. She's my mom, after all, but we understand each other better now. I also learned something important about anxiety and physical illness. They're not opposites. I really do have anxiety disorder. I really did have panic attacks last year, but I also really had myocarditis. Both things were true at the same time. Understanding that has helped me be more patient with myself and with others who struggle with invisible illnesses. But mostly, I wanted to thank you for believing me when no one else did, for trusting that something was wrong even when the test said I was fine, for doing that second examination when you could have just sent me home. You saved my life, Dr. Coleman. Not just in the dramatic stopped my heart from failing way, though you did that too, but also in the way you showed me that my concerns matter, that I deserve to be taken seriously. That being young or having anxiety doesn't mean my physical symptoms aren't real. I want to go to medical school someday. Maybe become a cardiologist, maybe emergency medicine, I haven't decided yet. But I know I want to be the kind of doctor who listens to patients the way you listen to me, who doesn't dismiss concerns just because they don't fit the expected pattern, who trusts their instincts even when it would be easier not to. Thank you for being that doctor for me. Sincerely, Madison Torres. P.S. My mom says hi and also thank you. She's still working through her guilt about almost convincing you to discharge me, but she's getting better. I fold the letter carefully and tuck it into my locker. It's the kind of letter that reminds me why I chose this profession, even on the hard days when nothing seems to go right. Over the next few months, I think about Madison's case often. Whenever I see a teenager with chest pain, I remember to look beyond the obvious. Whenever a parent tells me their child is faking, I remember to verify for myself. Whenever initial tests come back normal, but something still feels off, I remember to trust my instincts. 1 year after Madison's presentation, I get another letter. This one is shorter, written on a thank you card with a picture of a heart on the front. Dr. Coleman, just wanted to update you. I'm doing great. Heart function is completely normal. I'm off all medications. I ran my first 5K last month, something I never thought I'd be able to do. I also got accepted into a volunteer program at the hospital. I'm going to be working in the E1 afternoon a week, helping with patient intake and support. Maybe I'll see you there. Thanks for everything, Madison. 2 weeks later, I'm documenting notes at the nurse's station when I hear a familiar voice. Dr. Coleman? I look up. Madison is standing there in volunteer scrubs, a badge clipped to her pocket, looking confident and healthy, and so far removed from the pale, scared girl on the gurney a year ago. Madison, you're volunteering here? Starting today. They assigned me to the EO because I have experience as a patient here. She grins. Thought maybe I could help other people feel less scared. That's wonderful. How does it feel to be back? Strange. Good strange though. Like coming full circle. She glances around the IDM bays. The same monitors, the same controlled chaos. Bay 11 is empty today. That's where I was, right? Yeah, that was your bay. Weird to think that a year ago, I was lying in there thinking I was going to die. And now I'm here voluntarily. You've come a long way. We both have. You were just a few months into residency when you treated me. Now you single quotes double quotes. She trails off. Still a resident, I guess, but a more experienced one. I laugh. That's one way to put it. A nurse calls Madison over someone needs help with patient transport. She waves at me and hurries off, already getting to work. I watch her go, this teenage girl who almost died because of a diagnosis that was missed multiple times, who recovered because someone finally listened, who's now dedicating her time to helping others navigate the same scary place that once felt like the end of her world. Sometimes in medicine, you don't get to see the outcomes. You stabilize patients and send them to other departments, other hospitals, other specialists. You do your part and then they disappear from your life, and you never know if they lived or died, recovered or suffered. But sometimes you do get to see the outcomes. Sometimes patients come back, healthy and whole, living proof that the work matters, that the long hours and the difficult decisions and the constant second-guessing are all worth it. Madison Torres is that proof for me. She's a walking reminder that clinical vigilance saves lives, that trusting your instincts matters, that the art of medicine is just as important as the science. I turn back to my computer, back to the charts that need documentation, back to the work that never ends. But I'm smiling, because today, I got to see what success looks like. I got to see why I do this job, even on the days when it feels impossible. Sometimes heroes don't wear white coats. Sometimes they're patients who survive against the odds, who turn their trauma into purpose, who come back to help others navigate the same journey. And sometimes, if we're very lucky, we get to be part of their story, not the main character, not the hero, just a supporting player who showed up at the right time, made the right call, and gave them a chance to write the rest of their story themselves. That's the real reward of medicine. Not the dramatic saves, not the gratitude or recognition, but the quiet knowledge that you made a difference, that you listened when others didn't, that you trusted your instincts even when it would have been easier not to, that you fought for a patient's life when it mattered most, and that sometimes, miraculously, wonderfully, impossibly, you win.